Hello everyone and good evening. I'd like to welcome any new participants as well as welcome back any previously participating people joining us tonight. And before I introduce myself, I'm going to direct your attention to your computer screen, which should have a poll in front of you. It asks which profession or role do you represent. So if you could just answer that by clicking on whatever answer applies best to you. So it's my pleasure to welcome you all to tonight's Interprofessional Virtual Grand Rounds presented by the American Academy of Developmental Medicine and Dentistry. My name is Michael Tarr and I'm a third-year medical student at New York Medical College, and I'm the AADMD Virtual Grand Rounds facilitator. So let's look at the poll results we have. So tonight joining us, in which profession or role do you represent? We had 24% of participants answer administration, 6% said medicine, 24% said dentistry, and 47% said other. All right, I'm just going to bring up the second poll as I continue to talk about the grand rounds. So this next question asks, in which stage of your career are you in? So the AADMD Virtual Grand Round sessions seek to create a space for mentorship and exchange of knowledge and experience between seasoned IDD providers, entry-level clinicians, and future healthcare providers in training. The purpose of the Grand Round sessions is to expand and strengthen the IDD healthcare workforce across a spectrum of experience levels. At the end of the presentation, please stay on with us to ask any questions you have for the presenters. Questions can be submitted at any time throughout the presentation through the Questions tab on your gray control panel you can see on your screen. All right, so I'm going to close this poll now. And so when we asked in which stage of your career are you in, we found that 20% of the people joining us tonight are in pre-health profession training, 27% are health profession training, 7% are in the residency, 40% are currently practicing, and 7% are retired from practice. All right, I just have one more poll for you. And the last poll asks, what do you hope to gain from this webinar? So at the end of the webinar, you can follow the link that I just sent in the chat box. And that link goes to a SurveyMonkey survey that should take only 5 minutes to fill out. And the feedback we received from this survey allows us to improve the virtual Grand Rounds experience and also to hear what future presentations you'd like to have us organize. Also, tonight's presentation can be downloaded under the Handouts tab located on the gray control panel on your screen. So if you'd like to download that and follow along, we invite you to do so. So I'm just going to close this last poll. So when we asked, what do you hope to gain from this webinar, we found that 31% said they're looking to learn foundational healthcare concepts for individuals with IDD, 6% said networking, 31% said gain interprofessional perspectives on healthcare for individuals with IDD, 31% said gain pearls from complex and challenging clinical cases. Great. So with that, I will introduce tonight's presenters. Tonight we have Dr. Thad Woodard and Lieutenant Commander Molly Rutledge joining us. And Thad Woodard, MD, received his Bachelor's in Science and Chemistry from Bowling Green University and then went on to complete both his medical school training and residency at the University of Tennessee Medical Units. Following residency training in pediatrics, he worked for 2 years as a medical epidemiologist for the CDC and was assigned to Alaska, where he worked with the State of Alaska Division of Public Health. After completing his assignment, he entered private practice as a pediatrician in 1980, and he continues to work as a pediatrician in Anchorage with a special interest in allergy and asthma. Dr. Woodard currently hosts a weekly show on NPR radio. And Molly Rutledge, Lieutenant Commander and Master's in Science, is an active duty officer of the United States Public Health Service. She also holds both a bachelor's and master's degree in speech language pathology from the University of Kansas. She has continuously been assigned to the Indian Health Service and is now stationed in Anchorage, Alaska, where she provides services in the Inpatient Pediatrics Division at Alaska Native Medical Center. In 2016, Molly was selected as a subject matter expert by the Alaska South Central Area Health Education Center for her local contributions in speech-language pathology. I would also like to thank Rain Vandenberg, who has been pivotal in bringing everyone together and making sure this webinar was ready for all of you to enjoy. So with that, I will hand the floor over to our presenters.
Let me show the next slide. Mike, thanks very much. We're trying to get the next slide. So this is me on the left. It looks like I'm an airline pilot, but that's taken from the radio program. To my right is Molly Rutledge, the speech-language pathologist with the Alaska Native Medical Center. Below on the left, Rain Vandenberg, who helped get us all in the same place and help us get organized. And also, just briefly, we're going to meet Valerie Schmitz, also a speech-language pathologist and Lynn Fellow in Alaska, and is the treasurer of the American Academy of Developmental Medicine and Dentistry, the UAA, University of Alaska Anchorage chapter. So I'm going to let Valerie talk a little bit about what that's all about and how she became involved with this program.
Okay, thank you. Our AADMD club is the first to include more than medical and dental students. Because we don't have a medical or dental school here in Alaska, we created an interdisciplinary club with a broader audience of healthcare providers. The club was started by the Alaska LEN program, and many LEN fellows participate. Because of our commitment to interdisciplinary care, we wanted to host an interdisciplinary virtual grand round session.
Next, this slide just kind of gives us an overview of where we're trying to go and what we'd like to accomplish today. I'll speak just very briefly about some health disparities and barriers to patients with intellectual disabilities and developmental disabilities, and then Molly's going to present a couple of cases. They will be the bulk of the presentation is Molly's doing, and then at the end there's a short video of an interaction with a pediatrician known as myself and one of my patients, and demonstrating perhaps some skills or some opportunities to take advantage of when interviewing and dealing with patients with developmental disabilities. A couple of comments on autism, and then we'll share the resources and links that we would suggest. So it's pretty clear, the evidence is, I think, very good that there are clear health disparities for people who have intellectual or developmental disabilities. And the purpose of this program is to talk about some of the communication issues, and I'm going to briefly just also make a point that I think is very important, is that there's a difference between health and health care. And when you look at the overall health of a community, health care is not actually a big part of it. Although we're going to be talking about a lot about health care, socioeconomic factors are a huge portion of what happens to people is related to health. And people with intellectual and developmental disabilities are, as a group of people, more disadvantaged socioeconomically. So we need to keep that in mind as we talk about things. They have much poorer health, and to give you just some clarity on this, individuals, men and women who have intellectual and developmental disabilities have about a 15 to 20 years shorter lifespan than the average American. However, today we're going to talk about barriers that also contribute to these problems, and barriers to communication are certainly one of them. Lack of time, which to me always gets back to money and where we're putting money in healthcare, and generally we are not allotted a significant amount of time in situations like this. And although we may be very, very good at some of our very succinct healthcare specialties, particularly cancer care and some of the surgical subspecialties, we are not particularly good in this country with continuity of care, and that really also reflects in the care and outcomes of individuals with developmental disabilities. Additional barriers to care can also get down to the fact that healthcare providers can often presume that patients that they're dealing with are really incompetent to participate, and that can often be shown to be a very significant error. And in addition, it's been shown that our training is not adequate to support and interact correctly and appropriately with individuals with intellectual developmental disabilities. So given that, I'd like to go ahead and let Molly begin the first of two case presentations.
Thank you, Dr. Woodard, and I also want to thank the AADMD for allowing me to be here today. I'm very grateful to be able to present some cases for you all. So this first case I'm going to be presenting is my adult case for tonight, and this is a gentleman by the name of Richard. Richard lived on the Navajo Reservation, and I saw him as an outpatient. And he was an individual that experiences Down syndrome. He wore glasses, but he had typical hearing. He was exposed to some Navajo language in addition to English in his home, and he was essentially nonverbal when he came to me. But it was known that possibly his receptive language skills were higher than his expressive, meaning he possibly understood more than he was able to express. So what was a challenge about Richard is that he really had intermittent school-based services during his school-age years. He really had not been exposed to direct therapy services since the age of 21. And we talked a little bit, again, from Dr. Woodard about some of the barriers to care, and those certainly apply to Richard. He just really didn't have access to consistent services. He had elderly parents. He was born to them later in their parenting years, so he lived at home with these elderly parents all day, every day. And I was told, you know, he had his own bedroom, but he pretty much just spent all his time in his bedroom, which led to possible social isolation and also geographical location. Again, being in the remote area of the Navajo Reservation. He had challenging behavior since his primary years, including physical aggression and some property damage. So Richard was referred to me as a speech-language pathologist for communication therapy. He arrived to his first appointment with his mother and father nonverbal, but he was attentive and did make eye contact with me when we first met. So that's kind of how he came to me. I just was told, here's an individual experiencing Down syndrome. He's in his 20s. Can you help? So one of the most important aspects for me was to get a case history. Of course, I had some medical records, but I always make a point to speak with the individual and with the caregivers to find out if what I have in front of me is accurate with what they're reporting. So one of the things that I like to do is talk about daily routines and activities, because really, again, as we talk about healthcare and health, that health aspect about what are they doing throughout their day, and how's that going for them in their daily living? How are they navigating that? So I say here, sometimes it's almost like an onion scenario. I like to think that, you know, sometimes it may take several sessions. You're kind of peeling away these layers of essentially getting more information as the patients and their caregivers feel more comfortable with you. So it may take a little while to get to some of this information that's helpful, but you know, I think if you're patient and you hang in there, you will get some ideas to work with. So for Richard, it was found he had a high interest in watching DVDs, and he also had a high interest in listening to music loudly in his bedroom. And there was some talk about that he was interested in his younger nieces and nephews. So with that information, what I initially knew I could do, I had some things that he was interested in, so that's what I wanted to work with. And one of the things that I thought of was creating a low-tech option for him for communication. And by low-tech, I mean very simple paper picture method. So, you know, I wanted to make it concrete, but still very easy for his caregivers who had limited resources and not a whole lot of advanced technology in their home. So we created a sheet of paper that basically had a picture of movies and a picture of CDs. So DVDs, CDs. He did know the difference. He could recognize, of course, the DVD box and the CD box. So we just kind of started with those two things. They were high interest activities to him, and you know, just allowing him to have some choice making in his daily, again, routines and activities. That was important to us. So I'm just looking at my slides here. So really, this again, low-tech options require minimal communication skills. And only a simple motor movement of pointing or touching with their hand. And the research has shown that individuals experiencing IDD may show improvements in their spoken language. with just some access to simple communication techniques such as this. So I also like to think of LowTech Options as being similar to a pain rating scale, which I believe some of you that may be in attendance tonight probably have seen these pain rating scales. But really it's just giving an individual a way to communicate how they're feeling without having to verbalize it. So I just kind of wanted to show that to me, that is a low-tech communication system as well. So there's also something that we call high-tech communication systems, and these are beyond the paper picture examples. So high-tech communication systems are multimodal, they permit storage and retrieval of messages, and they allow for speech output. And of course, they're rapidly changing and improving, and it's one of those things where you just have to chase to keep up and make sure that I'm keeping up with how much technology is advancing. But here I give you some simple pictures below. They can go from just something that's like a small smartphone to, on the right side, an assistive technology device, which is specifically created for communication output. Okay, so along the lines of high tech, I also wanted to present this case study of Ashley. So now we're going to kind of come back to a pediatric age group. Ashley is a 9-year-old female. She was admitted in an inpatient setting. Again, Richard was outpatient, Ashley's inpatient, for gastric dysmotility. She had a history of neglect resulting in foster placement, nonverbal, but we believed actually had close to age-appropriate comprehension. Her vision and hearing were in normal limits, and she was G-tube dependent with some oral feeding. So again, complex medical history. She had intermittent school-based services similar to Richard, but they weren't consistent. And again, this is an individual that had experienced living in remote villages in Alaska. So the common theme here is there's some barriers to care with both of these individuals. She did have some challenging behavior since her primary years, including physical aggression and some self-harming behaviors. So Ashley was referred to me in the inpatient setting basically because the staff was noting, she's really difficult to communicate with, we're having negative behaviors, we really just don't know what to do. So in this setting, what I like to do is really, again, observe her interactions and observe them with staff, with her caregivers, get an idea of what her tech experience was. With Richard, I mentioned he didn't have a lot of resources in his home to have a computer or a laptop, so that's why we chose to really start with those pictures. But for this individual, she had some tech experience in her intermittent schooling. So I had to look at that, and then also her high interests again. What is she interested in? What are her daily routines and activities? And also, what is her physical ability? So these are some examples of, again, this is kind of a blend of high-tech, low-tech, but these are just examples of things I may use with an inpatient. So we have on the left, this is, again, more of a high-tech option. It has a speech output where they could touch the picture, and then the device would actually say what their intention is. The middle one is an example of an application that can be put on an iPad. And then on the right, again, this is more of a low-tech option, but it's really for the hospital setting where the individual may be able to tell their doctor or their nurse, hey, something's wrong, this hurts. And so, again, those are just some options that we used with this individual in the inpatient setting. So, okay, so I'm going to go over some free and low-cost apps for healthcare providers here. So again, I was mentioning these are things that we found to be very helpful for this patient. Again, I was her therapist, but I saw her readily use some of these technology options with her caregivers and with the medical providers when she was inpatient. So I have a few suggested here just as maybe something to consider for your practice. They do have pain scales that you can easily put onto your smartphone, as well as a yes-no board. So you may be able to, if you're seeing a patient and you're not getting any consistent yes-no nodding, or you're just unsure, this might be something that would be really helpful to have on your phone that you could pull out and see if your patient's able to answer that way. And then a couple other that are a little more advanced, but again, very low cost, Speak Aid and My Choice Board. So these would look similar to that like the healthcare board that I showed for Ashley, where you can actually have some pictures to describe how your your health is going or how you're feeling. So again, these could possibly be very helpful for a provider to have easily on their phone or their iPad in their office, just to aid in that communication and making it easier for everybody. So as a review, assessment of language skills can be very valuable. So you want to see, is this an individual, is this person a yes/no communicator, or is this person maybe can label some body parts, but really it's very limited, so pictures are beneficial. It's really getting an idea of where they are with their skills. Again, like we did with Ashley, we knew that she could do some, and she had some exposure to the technology piece, so that was a route that we were able to go with. I always like to involve the caregivers as much as possible. So for Richard, I was able to talk to his parents and learn that, yes, he loves music, he loves DVDs. So how can we build on that to help him be an improved communicator? And then identifying high interests of the individuals experiencing IDD. Again, like I said, you want to find out what are their daily routines and activities and what really motivates them, and try to incorporate that into your practice. And again, consider adding a few low-cost communication aids on your phone or your tablet device, because those may very well come in handy when you're faced with a challenging communication situation.
So next what we're going to do is present a short video of myself working with a patient named Colin. Colin is a 20-ish aged boy, believe it or not, and he had a very unfortunate intrauterine environment. He had a large intracranial bleed which led to a large what's called porencephalic cyst and some hydrocephalus, and so you can see some scars on the upper part of his head there. His head is very misshapen if you pay attention to the video that's coming up. However, despite that, his receptive language skills are pretty good. They're slow in his processing, but he's good. He is handicapped particularly with visual acuity, and you'll notice that he has to look in certain ways, move his head in certain ways to really get a good view of what's happening. His hearing is excellent. And he does have some expressive language, not a lot, but he processes a lot more than you would think, and he has a very subtle humor about him, which unfortunately doesn't come out in the video. So what we're going to do is show you the video, and then Rain is going to make some comments on what she notices out of the interaction.
Hi, Colin. How are you? Woodard's going to be happy to see you. Okay. I've done everything I need to do here. So we're going to send it over to Woodard, okay?
I didn't know it, Cal. You know what, the last time I saw you, what was going on? You broke your foot.
And
I'm okay. Are you okay? You feeling all right? So how's your foot? You know, recovered completely? I mean, that's the big sort of thing.
it took a long time.
Go back. Okay. Go take a listen to your heart. Okay. Let me look at your ear. Can I look at your other ear? Just like this? It doesn't hurt. I gotta do the looking. I'm afraid if you hurt yourself if I do that. Okay? Hold on. I'll let you look at my ear if I get to look at your ear first, okay? I'm not gonna hurt you. There you go. Good job. Now you want to look at my ear? Hold on. Hold on. Look right in there. You're amazing me all the time.
So I love this video because it shows some important things about
working with a patient with limited verbal skills. Dr. Woodard is a master at kind of being respectful and engaging with the patient directly, and he used a calm tone, short, direct sentences. He allowed for that processing time that Colin needed, and he really he explained and demonstrated what he was going to do before he did it over and over for each part. Even though he'd just done the right ear, he demonstrated again before he did the left. He gave Colin a little bit of time to look at the instrument that he had in his hand, and just those little things really helped Colin be more comfortable in the encounter. And one thing I really like about this is it shows how he was able to gain information from the caregiver that was in the room while still really staying present with the patient. So through his body language and being close to Colin and still really with Colin, and he kind of glances over to the parent and asks some questions, but he's still kind of physically and you know, his presence is there with the patient. So, so I just appreciate all of those.
Okay. Next, we're going to make I'm going to make just a couple of comments related to patients with autism. We're clearly all seeing more patients with autism, and I have to say, as a clinician, there's a broad spectrum. What we diagnose as autism nowadays is getting a little wild at times. Colin was not an autistic individual, in my opinion, but you can see many kids with intellectual and developmental delays having that label, unfortunately. I like to think of the most important thing with any patient is beginning to show some caring and empathy as I walk in the room, try to make contact, see what people are interested in, not make it a purely medical visit from the very beginning. And then it's very important to establish where's our level of communication. And with patients with autism, you can get fooled a little bit. There's a very broad level of communication abilities in the spectrum of autism, and you can be fooled by the responses of some patients with autism into thinking they understand much more than they really do. And sometimes it may be very beneficial to speak with the caregiver or parent to ask them to also comment on you know, is John really understanding what I'm saying? He acts like he might have a feeling he probably doesn't. Sometimes it's a good way to get into that. I think it's very important to talk with patients. And maybe as a pediatrician, I'm caught up in that. I talk to every patient I see as if they're my patient, even if they're 6 months old. But I think it's a good thing to carry over, particularly with these patients with intellectual disabilities. And I think it does help increase the communication and the feeling that they're willing to work with you if they possibly can. Patients with autism have a tremendous amount of anxiety, and it's very important to not be in a hurry and have this, if possible, schedule with more time. Remain extremely calm as much as you can. They can be challenging behaviors with some autistic kids, and staying in control helps them stay a little bit better in control as well. As I did in the video, I think taking time to really explain and demonstrate what you're doing. Sometimes I'll demonstrate on a parent before I demonstrate on a child the procedures that we're about to go through so that they can see what's happening. And often if they see that the parent is accepting of it, it's much easier for them to accept the same kinds of procedures and discussion. As I did, again, letting them see and feel equipment, touch it, not be in any big hurry. And again, I'm constantly think it's very important to try to assess as best you can where you are and with the patient's understanding of what's happening. Finally, we just going to have a couple more comments that are kind of supporting issues in all kinds of communication with patients with intellectual disabilities. Throughout the presentation, there's been comments about trying to speak kind of slowly. Make sure patients are having plenty of time to process the information that you're given. It helps to use as simple and as direct of statements as you can. One thing that I don't believe we have mentioned today is the teach back strategy, where you ask them to tell you back as best they can what you've suggested to them, what you've talked about, and that's a good strategy, frankly, for any kind of interaction with patients. trying not to get too much done in a particular visit. Maybe trying to prioritize as much as you can very quickly about what's most important and limiting that information to that particular problem or concept that you're trying to get across that particular day. As Molly pointed out, there's some other strategies and equipment and supports that you may take advantage of to take advantage of visual ways of communicating as well as auditory. And then, as is another just generally good and important rule, if you can provide some kind of written take-home message for patients, I think it's very useful. We're going to complete today or finish what we're doing with Rain's going to talk about some of the resources that we think might be valuable.
So I wanted to highlight that the clip that we showed of Dr. Woodard comes from a longer 12-minute video around communication skills and strategies, some of them that we're talking about today, but the link for the full clip is there. And also the second one, which there should be a bullet there, is DD Cares, and that comes from Canada. Canada is doing some really great things related to their care, overall whole person care related to adults with intellectual disability. And so this video features a man who experiences autism at a primary care visit, and it just really does a nice job how they address his sensory needs, how it's kind of like common practices that maybe aren't working so well, and then best practices. So recommend that link. And then My Health Toolkit is a project that LEND in Alaska has developed, and it's a resource for individuals with IDD and their families and caregivers. And it has kind of the patient side of this equation, resources that they can use to improve their side of the communication, being more prepared for visits, how asking questions while they're in the visit to make sure they understand, those kind of things. And it also includes health promotion and some other just general health resources, so you can check that out. If you're not familiar with the Vanderbilt Healthcare for Adults with IDD, the toolkit, a very good toolkit, and then a specific handout that has really nice, it's just a one-pager with communication tips for IDD is there. And then I also wanted to share that our club developed a training kit if you wanted to host an event around the communication skills that are demonstrated in that 12-minute video. We have kind of an outline for a 45-minute to 1-hour session. This can be delivered in classrooms. It makes a really nice AADMD lunch and learn event, and I'm happy to send that to you, and just my email is there.
Mike, that completes our presentation, and we would be more than happy to answer questions and address comments that listeners have.
Yeah, so if anyone who's listening has any questions, please feel free to write them in at this time. I really liked the application, like the phone apps idea. I think that hospitals should really think about adopting things like nonverbal communication augmentation devices, especially not just for individuals with intellectual disabilities, but also if you think about how many debilitating stroke patients are working through trying to get back their communication skills and really don't have any other way other than maybe blinking or tapping their fingers. But if they were able to use an application on a phone or something, it just might make it that much easier.
Thanks, Michael. Yes, I agree. And, I think it kind of depends on the setting that you're in, but I agree. I think we could all maybe advocate for some more of those resources to become more common practice. Of course, I'm exposed to them, readily as a speech-language pathologist, right. But one of my goals is always to really familiarize the physicians with these and let them know this is a helpful tool, and it will enhance your practice. So I think anybody from a small to a large setting trying to advocate for their team to have those resources is wonderful.
Let's see. All right. One person asked if you have any additional resources for working with individuals with IDD and dementia. I know you already listed a handful, maybe some that are specific for dementia. Or...
I don't have any specific for dementia. There is a good a toolkit for communicating effectively with seniors. That's kind of in a similar format to the handout that was featured around with adults with IDD, and that has some specific tips for dementia. And I think, you know, some of the strategies do cross over, like allowing for more processing time. Visual aids sometimes can be helpful. Any other ideas?
I don't have it.
So, Michael, I could send that other handout if that would be helpful.
I might just add to that maybe, you know, access to calendars for those individuals. So for the memory piece, so having either just a very basic, simple calendar that the provider could write next appointments on, or, you know, something very simple such as that may be beneficial. So kind of, you can think low tech on some of these things just as a start, and then explore more high-tech options.
Right. Let's see. Sorry, for some reason, making it difficult for me to read the questions. This next one asks, do you know of any codes that you can claim for reimbursement when communicating with a nonverbal or alternatively verbal individual? Because their staff are often an interpreter in practicality.
Right. Yeah, I'm not aware of a particular code for that. We use some translation equipment in the office. We also, at times, will call a translation service. We have patients with multiple different languages and cultures in our office, and to my knowledge, we do not get any reimbursement for that, so I'm not aware of any codes. I have, this is maybe a little off the subject, but I was just somewhere recently and became aware of Google Translate, which is a free app that allows you to scan documents that might be in a certain language, and it automatically translates it for you. That's maybe a little bit off the cuff, but I've been waiting for a place to throw that in. I tried it a little bit at home and was surprised that it worked. So there's a lot of these things out there. But as far as coding, which was the direct question, I personally am not aware of that, any codes for that.
Thank you. Next question asked, does the interdisciplinary team work with behavioral analysts?
Yeah, I'd say ideally. I think it's behavior modification, if I'm understanding the question right, and dealing with that is extremely important part of dealing with just the normal patients that I deal with daily, but particularly maybe with patients with intellectual disabilities. In our office, we have a social worker who deals with behavioral issues, parenting issues, and some of that kinds of stuff. But specifically, having a behavioral specialist would be very beneficial. As you're probably very much aware, it's extremely important, if not the state of the art, for dealing with patients with autism, to have applied behavioral analysis, which is, to me, a very sophisticated behavioral modification program, and it can be very helpful.
Thank you. This next question asks, who referred Richard to care? In other words, how did he come to seek help?
Thanks. Yes, so Richard was referred from his primary care provider. And, you know, I think that may sound kind of like, that may still be scratching your head on that one, but I think because of the Navajo reservation and the remote location, some primary care providers actually change quite frequently, unfortunately. So, you know, I believe he had a new provider that came and probably was thinking the same thing we all would be thinking, you know, why do you not have any access to communication, to functional communication? So so that was not uncommon in that location. But again, you know, whether you're remote or in a metro area, I think we certainly can encounter similar situations regarding, because the barriers are still there, but sometimes they're just different.
That makes sense. Thank you. I like this question. It says, if you have difficulty with communication, or if communication through talk is difficult, do you ever try communication through music or song?
I can answer that. You know, I don't have a degree in music therapy per se, but I have had. I was actually just talking about this case the other day with a colleague, and you know, I've had some individuals who've come in for treatment and are just, and this was a, I believe this child was under 10, but not probably, you know, between 5 and 10. And she was an individual that experienced IDD, and she just was out of sorts, just upset. And I believe she came in with, not her mother or father, came in with another caregiver. And then, you know, I was thinking, you know, what do I do? And I did a great question about behavior support, because often in sessions, no, they're not going to be right there for you. So I had a CD of traditional Navajo music and it was I think it was just, you know, traditional Navajo music as nursery rhymes. And so I put that into my player, and she just immediately calmed. And the caregiver and I just kind of looked at each other and thought, oh, thank goodness, you know. But I always remember that, and I do think there's a special time for that sometimes. And it's hard when that's not your, you know, if you don't have that degree, but if you can access individuals or get some of those tools too, you know, I mean, that was something I think, and I actually used that several times, not just with her, with other individuals. So yeah, finding a calming music, whether you're with a certain culture or not, that it possibly could really enhance your practice. I don't know if Dr. Woodard, if you've ever had to do anything similar, but
yeah, this is not really, I have to admit, my area of expertise, but I can say that recently there's an increasing awareness of, well, a couple of points. One, kids with autism are often, the parents are realize that music can help keep these kids behaviorally under control. And fortunately, that means without medication sometimes, so that can be very beneficial. But where I wanted to go is that I think we're increasingly aware that the brain has different areas than just our receptive and expressive language, and that particularly in strokes and head injuries, it's been found that, and in dementia, that the ability to use music and take advantage of music can help with therapy. And I'm hesitant to say communication because I can't recall anything specifically like that. But I think in rehabilitation, it's being shown that there is, in my mind at least, and again I could be wrong, that there are very well localized areas where people who have lost the ability to have memory and so forth can remember songs, can recover more quickly with stimulation with music from neurologic impairment, their injuries and so forth. I think that's true. I'm sitting with two speech-language pathologists, so I'm very careful about that. But I think it's very interesting where some of that information is going, if I'm aware of it.
Right. I think that goes to what we were saying before about how, especially Canada is looking into holistic approaches, as is all of medicine. And I think that we're finding every day how important it is to look at our patients as a whole and not just approach them with medications, but see what other interventions that are less harmful are available. All right, so I don't think. So at this point, we do not have any other questions. I'll give it another second. While I do that, I'll just remind everyone that earlier in your chat box, I posted the link to the survey. If you don't have time to complete it tonight or you forget, that's okay. Tomorrow you will receive a follow-up email from GoToWebinar, and that also contains the survey. And in the next few days, this webinar will be uploaded to the AADMD YouTube page, which has the recordings from all of our previous Virtual Grand Rounds presentations. And if you can't find it on YouTube, you can just go to aadmd.org, and it is on the front page, the link to the YouTube channel. Let's see. Oh, we do have one more question. So this says, this is more of a comment than anything. It said, I'm somewhat familiar with attainment companies' Go Talk talking boards. I think their best asset is that they are customizable and patients can draw their own pictures and record as well if they wish. It's more low tech than the high tech. Which is good.
Yes, that's all correct. Mm-hmm. And they're very portable and easy to clean. So you can easily just take them if you need to use them for multiple patients, depending on, of course, the patient's precautions. But yeah, they're a nice choice for a hospital setting.
Yes. And they're far less expensive than some of the other equipment in the hospital.
That's right.
All right. Well, this time we don't have any other questions, so I want to thank all of our presenters very much for taking their time out of their day and coming together and giving this excellent presentation. If anyone has any further questions later on, my email is attached to the flyer you used to sign up for this. And other than that, I just would like to say have a good night.